Let's talk about ketamine. Of all the drugs in anesthesia, ketamine might be the most misunderstood. Patients know it as a club drug. Veterinarians know it as an animal anesthetic. Psychiatrists are now using it for treatment-resistant depression. And anesthesia providers know it as one of the most versatile, clinically powerful drugs in the entire formulary. No other induction agent provides analgesia. No other induction agent stimulates the cardiovascular system. Let's go through all of it. Chemistry and formulation. Ketamine is a phencyclidine derivative, chemically related to PCP, which explains many of its dissociative and psychedelic properties. It is formulated as a racemic mixture, containing both the R- and S+ enantiomers in equal amounts. The S+ enantiomer is pharmacologically superior in several ways. Approximately twice the analgesic potency of the R- isomer, faster recovery, less salivation, lower incidence of emergence reactions. S+ ketamine, also called S-ketamine, is available as a separate preparation in some countries, and is the formulation used in the intranasal S-ketamine approved for treatment-resistant depression. For standard clinical use in anesthesia, the racemic mixture is most common. Ketamine is water-soluble, no lipid emulsion required, no pain on injection. Unlike propofol, ketamine does not support significant bacterial growth. Aseptic handling is still required, but the concern is lower. Mechanism of action. Ketamine's primary mechanism: non-competitive NMDA receptor antagonist. The NMDA receptor, N-methyl D-aspartate receptor, is a glutamate-gated ion channel that allows sodium and calcium to enter the neuron when activated. Glutamate is the brain's primary excitatory neurotransmitter. NMDA receptor activation, excitation, pain transmission, memory formation, consciousness. Ketamine blocks the NMDA receptor by binding to the PCP recognition site, the phencyclidine binding site, located inside the channel. This is an open channel block. The channel must open first. Ketamine enters and blocks it from within. The result: reduced glutamate-mediated excitation across pain pathways, consciousness circuits, memory networks. This is what produces the unique dissociative state, a state where the patient appears awake, eyes often open, nystagmus present, in a cataleptic state, but is completely disconnected from their environment. Not sedated in the traditional sense, not unconscious in the traditional sense, dissociated. The thalamus and limbic system are functionally disconnected from each other. Ketamine also interacts with additional receptor systems, opioid receptors, contributing to analgesia, monoaminergic receptors, dopamine, serotonin, norepinephrine, contributing to antidepressant effects and sympathomimetic properties, muscarinic receptors, contributing to increased secretions, voltage-gated sodium channels, local anesthetic-like effects, nicotinic acetylcholine receptors, contributing to bronchodilation, weak GABA activity. This complex polypharmacology is what makes ketamine so clinically versatile and so pharmacologically unique. Sympathetic effects specifically, ketamine inhibits catecholamine reuptake, similar to cocaine, and stimulates central sympathetic outflow. The result: increased heart rate, increased blood pressure, increased cardiac output. This is the opposite of every other induction agent, and is what makes ketamine the drug of choice in hemodynamic instability. Induction 4. Induction dose: 1 to 2 milligrams per kilogram. IM. Induction dose: 4 to 8 milligrams per kilogram. The intramuscular route is an important and practical advantage, particularly in pediatric patients, or in situations where IV access is not yet established, trauma, combative patients, or field anesthesia. Loss of consciousness after IV, 30 to 60 seconds. After IM, 2 to 4 minutes. Recovery, 10 to 20 minutes to adequate arousal. Full orientation, 60 to 90 minutes. This delayed full orientation compared to propofol is an important clinical consideration, particularly for outpatient procedures and discharge planning. Sub-anesthetic analgesia, 0.2 to 0.5 milligrams per kilogram IV. At these doses, Ketamine provides powerful analgesia without full dissociation, without loss of consciousness, making it an incredibly useful adjunct for acute and chronic pain. Pharmacokinetics. Distribution. Highly lipid-soluble. Large volume of distribution. Approximately 3 liters per kilogram. Rapid blood-brain barrier penetration. This rapid CNS penetration produces the fast onset you see clinically. Metabolism. Hepatic. CYP450 enzymes. Primary pathway. N-demethylation. Ketamine is metabolized to norketamine, an active metabolite. Norketamine has approximately 1/3 the potency of ketamine and contributes to the prolonged clinical effects compared to what the parent drug half-life alone would predict. This active metabolite is also important for ketamine's analgesic properties, particularly during infusions, where norketamine accumulates and contributes meaningfully to the analgesic effect. Elimination. Hepatic clearance approximately 1 liter per minute. Renal excretion of metabolites. Less than 4% excreted unchanged in urine. Less than 5% in feces. Half-life. Elimination half-life 2 to 3 hours. Duration of clinical effect 3 to 5 hours. Clinical uses. Ketamine's versatility is unmatched in anesthesia pharmacology. IV induction, particularly when cardiovascular stimulation is desired or blood pressure support is needed. Trauma and hemorrhage. The sympathomimetic profile maintains blood pressure during active hemorrhage, making ketamine the induction agent of choice in trauma anesthesia. Burn dressing changes and debridement. Burns are among the most painful procedures in medicine. Ketamine provides excellent analgesia, maintains airway reflexes, can be given IM without IV access, and is titratable for repeated procedures. Pediatric anesthesia, particularly for procedures where IV access is difficult to establish. The IM route is invaluable, and the cardiovascular stability is favorable in sick children. Procedural sedation, emergency department, cardiac catheterization laboratory, endoscopy. Ketamine provides sedation and analgesia while maintaining airway reflexes better than most alternatives. Status asthmaticus. Ketamine is the induction agent of choice for the intubation of a patient with severe bronchospasm because of its bronchodilatory properties. Chronic pain adjunct. At sub-anesthetic doses, ketamine disrupts central sensitization, breaks the cycle of opioid-induced hyperalgesia, and provides analgesia in patients who've become tolerant to opioids. Opioid tolerance. Ketamine modulates opioid receptors and has been shown to reduce opioid consumption in the perioperative period, particularly in opioid-tolerant patients and in procedures associated with significant postoperative pain. Depression. Sub-anesthetic ketamine infusions produce rapid antidepressant effects within hours in patients with treatment-resistant depression. The intranasal S plus ketamine formulation, S-ketamine, is FDA approved for treatment-resistant depression. This represents one of the most remarkable crossovers in anesthesia pharmacology. A drug we use for induction of anesthesia is also now a frontline psychiatric treatment. Tolerance may develop with repeated dosing, requiring dose escalation over time. CNS effects. Ketamine produces a unique state unlike any other anesthetic, dissociative anesthesia. The patient appears awake, eyes often remain open. Nystagmus is characteristic. There is a cataleptic state. The body maintains its position without active resistance, yet the patient has profound analgesia, amnesia, complete indifference to their environment. The mechanism of this dissociation, functional disconnection between the thalamus and the limbic system. The thalamus, the relay station for sensory information to the cortex, and the limbic system, responsible for emotional processing and consciousness, are normally in constant communication. Ketamine disrupts this communication. Sensory inputs arrive at the thalamus, but cannot be processed or responded to by the limbic system and cortex. The result? A patient who appears present but is experiencing a world completely disconnected from external reality. EEG, excitatory activity, not the suppressive activity seen with propofol, burst suppression only at very high doses. This excitatory EEG pattern is consistent with NMDA antagonism, allowing relative disinhibition of certain neural circuits. ICP. This is where the teaching has changed significantly, and this is exam relevant. Old teaching: ketamine increases ICP. Avoid in head injury. Do not use in neuroanesthesia. Modern evidence: in mechanically ventilated patients with controlled ventilation, ICP is generally unchanged or actually decreased with ketamine. The mechanism of the old concern: ketamine increases CBF through sympathomimetic stimulation, which could raise ICP in a patient who is spontaneously breathing and already has poor compliance. But in an intubated patient with controlled ventilation, where CO2 is being managed, the increase in CBF is blunted or absent, and the ICP effect is neutral or favorable. Current consensus: ketamine is acceptable in traumatic brain injury with controlled ventilation. The contraindication in TBI is no longer absolute. Know both the old and new teaching. Exams are updating to reflect the modern evidence. Cardiovascular effects. Here is where ketamine is categorically different from every other induction agent. Propofol drops blood pressure. Etomidate minimally affects blood pressure. Ketamine raises it. The hemodynamic profile: increased heart rate, increased blood pressure, increased cardiac output, increased myocardial oxygen demand, all mediated through central sympathetic stimulation and catecholamine reuptake inhibition. This sympathomimetic profile is why ketamine is the preferred induction agent in the setting of shock, when the cardiovascular system needs support, not further depression. But there is a critical caveat that exams love to test, and that is clinically essential. Ketamine has direct myocardial depression. In an isolated heart preparation, ketamine is a negative inotrope. At clinical doses, this direct myocardial depression is normally completely masked by the endogenous catecholamine surge. The cardiovascular stimulation overwhelms the direct depression. Net effect: cardiovascular stimulation. But in a patient with catecholamine depletion, septic shock, prolonged critical illness, prolonged hemorrhagic shock, the endogenous catecholamine reserve is exhausted. When you give ketamine to this patient, the indirect sympathomimetic effect has nothing to work with. No catecholamines to release and prevent reuptake of. The direct myocardial depression is now unmasked, and you can produce significant hypotension in the patient you were trying to support. This is the most dangerous trap in ketamine pharmacology. The patient who looks like they should benefit from ketamine's sympathomimetic effects, the shocked, critically ill patient, may actually be at risk for cardiovascular depression if their catecholamine reserves are depleted. Relative contraindications for ketamine's cardiovascular effects. Severe uncontrolled hypertension. Ketamine will make it worse. Aortic dissection. Increased heart rate and blood pressure will extend the dissection. Acute myocardial ischemia. Increased myocardial oxygen demand in a heart that is already ischemic is dangerous. Severe pulmonary hypertension. Ketamine can increase pulmonary vascular resistance, which the already failing right ventricle cannot tolerate. Coronary artery disease. Use with caution. The tachycardia and hypertension increase myocardial oxygen demand in a coronary circulation that cannot adequately meet it. Respiratory effects. Ketamine's respiratory profile is one of its greatest strengths and is the defining reason it is used in the most critical airway scenarios. Minimal respiratory depression at clinical induction doses. Respiratory rate is largely maintained. Tidal volume is largely maintained. The ventilatory drive persists. The response to CO2 is better preserved than with propofol or barbiturates. Airway tone is preserved. Pharyngeal tone maintained. Laryngeal reflexes relatively maintained. The patient keeps their airway far better than after propofol. Bronchodilation. Ketamine is a powerful bronchodilator. It relaxes bronchial smooth muscle through sympathomimetic stimulation, and possibly through direct smooth muscle effects, and interaction with nicotinic acetylcholine receptors. This makes ketamine the induction agent of choice in active bronchospasm, status asthmaticus, and severe reactive airway disease. Critical warnings. Apnea can occur, particularly with rapid IV injection, with concurrent opioids, or with concurrent benzodiazepines. Do not assume ketamine means the patient will definitely keep breathing. Monitor closely. Ketamine does not eliminate aspiration risk. Even though airway reflexes are relatively maintained, they are not fully intact. A full stomach patient who receives ketamine is still at aspiration risk. This is a classic board trap. Ketamine preserves airway reflexes, but does not eliminate aspiration risk. Airway effects. Ketamine maintains pharyngeal tone, laryngeal reflexes, cough reflex. This makes it better than most induction agents for airway preservation, but it significantly increases salivary secretions and tracheobronchial secretions. This increased secretion production can cause laryngospasm in some patients, coughing, airway obstruction from mucus. The clinical solution: glycopyrrolate as premedication. Glycopyrrolate, an anticholinergic agent, reduces secretions without crossing the blood-brain barrier, so it does not produce the central effects of atropine, confusion, tachycardia that you might want to avoid. When you use ketamine, consider giving glycopyrrolate 0.2 milligrams IV beforehand, particularly in pediatric patients where secretion-related laryngospasm is a real concern. Analgesia. This is where ketamine truly separates itself from every other induction agent. Ketamine is the only induction agent that provides clinically significant analgesia, not as a side effect, not incidentally, as one of its primary mechanisms. The analgesia is intense, effective at sub-anesthetic doses, better for somatic pain than visceral pain, and remarkably opioid-sparing. Multiple mechanisms contribute. NMDA receptor blockade in the dorsal horn of the spinal cord, disrupting pain signal transmission. Opioid receptor interaction, direct analgesic contribution. Monoaminergic effects, contributing to central pain modulation. The sub-anesthetic dose range, 0.2 to 0.5 milligrams per kilogram, provides analgesia. In the perioperative period, low-dose ketamine infusions, 0.1 to 0.3 milligrams per kilogram per hour, reduce post-operative opioid consumption, reduce pain scores, and may reduce the development of chronic post-surgical pain, particularly in opioid-tolerant patients. In the emergency department, sub-anesthetic ketamine provides excellent analgesia for fractures, dislocations, and severe acute pain, without the respiratory depression of opioids. For patients with opioid tolerance, ketamine is invaluable. It provides analgesia through a completely different mechanism than opioids, and simultaneously modulates opioid receptors, potentially restoring some sensitivity to opioids that tolerance has blunted. Emergence delirium. This is ketamine's most clinically challenging adverse effect, and the primary reason many providers are hesitant to use it for routine induction. Emergence delirium, also called emergence reactions, occurring as the patient wakes from ketamine anesthesia, involves vivid, sometimes terrifying hallucinations. Visual hallucinations, auditory hallucinations, proprioceptive illusions, a floating or out-of-body sensation, bizarre and disturbing dreams, agitation, confusion, crying or screaming on emergence. Incidence, approximately 5 to 30%, depending on patient population and preventive measures. Risk factors, adults more than children, female sex, higher doses, rapid injection, personality disorders, patients with a history of psychiatric illness. This is why ketamine is actually better tolerated in children than adults. Children seem to process the dissociative state with less distress, and emergence delirium is significantly less common in the pediatric population. Prevention. Benzodiazepine pre-treatment. Midazolam, more effective than diazepam, significantly reduces the incidence and severity of emergence reactions. Quiet emergence. Minimize stimulation during recovery. Dim lights, quiet room. Limit unnecessary touch or noise until the patient is fully oriented. Lower doses. The incidence is dose-related. Use the minimum effective dose. Important distinction for exams. The midazolam you give to prevent emergence reactions will blunt the respiratory drive and may increase apnea risk, especially if combined with ketamine and opioids. Monitor carefully. Adverse effects. Myoclonus can occur, less prominent than with etomidate. Nystagmus, characteristic and common, an expected finding after ketamine, not a sign of pathology. Increased secretions, as discussed, a significant clinical concern. Nausea and vomiting occurs with ketamine, more than with propofol, less predictable than with etomidate. Rare allergic reactions. Minimal platelet inhibition, not clinically significant in most circumstances. Tolerance with repeated dosing. This is relevant in chronic pain and ICU settings. Tolerance to both the anesthetic and analgesic effects can develop with prolonged or frequent use, requiring dose escalation. Your top exam pearls. Before we close, the essential facts. 1. Phencyclidine derivative, racemic mixture R- and S+. S+ isomer, 2 times more potent analgesic, faster recovery, less emergence reactions. 2. Primary mechanism, non-competitive NMDA receptor antagonist, binds PCP site within the channel. 3. Also interacts with opioid, monoaminergic, muscarinic receptors, voltage-gated sodium channels, nicotinic acetylcholine receptors, weak GABA activity. 4. Water-soluble, no lipid emulsion, no pain on injection. 5. Induction, IV, 1 to 2 milligrams per kilogram. IM, 4 to 8 milligrams per kilogram. 6. Sub-anesthetic analgesia, 0.2 to 0.5 milligrams per kilogram IV. 7. Active metabolite, norketamine, 1/3 the potency of parent drug, contributes to prolonged effect. 8. Cardiovascular stimulation, increases HR, BP, CO, via central sympathetic stimulation and catecholamine reuptake inhibition. 9. Direct myocardial depression exists, masked by endogenous catecholamines, can unmask in catecholamine-depleted states, sepsis, prolonged shock. 10. Contraindications relative, severe uncontrolled hypertension, aortic dissection, acute MI, severe pulmonary hypertension. 11. Bronchodilator, drug of choice for induction in status asthmaticus. 12. Minimal respiratory depression, ventilatory drive preserved, airway reflexes relatively maintained, but does not eliminate aspiration risk. 13. Apnea possible with rapid injection, opioids or benzodiazepines. 14. Increases secretions, give glycopyrrolate as pre-medication. 15. No analgesia from other induction agents. Ketamine is the exception, potent analgesia through multiple mechanisms. 16. Emergence delirium, 5 to 30%, prevented by midazolam pre-treatment and quiet emergence. 17. Worse in adults than children, better tolerated in pediatric patients. 18. Produces dissociative anesthesia, open eyes, nystagmus, cataleptic state, dissociation of thalamus and limbic system. 19. ICP. Modern evidence shows ketamine is acceptable in TBI with controlled ventilation, Old teaching of absolute contraindication is outdated. 20. Clinical contexts where ketamine excels: trauma, hemorrhage, burns, pediatric anesthesia, status asthmaticus, opioid tolerance, chronic pain, hemodynamic instability, and now treatment-resistant depression. Ketamine, dissociation, analgesia, sympathomimesis, preserves airway, preserves respiration, stimulates the heart, opens the bronchi. No other drug does all of that. Respect its adverse effects. Understand its limitations. I'm Anesthesia Buddy. Stay sharp. See you in the next one.